morning, everyone, or good afternoon, I should say. It is 12 o'clock. And welcome to the town hall. Welcome back from a long weekend. Um, we were able to attend, many of us were able to attend the Memorial Day parade. I thank those who joined us and the veterans that joined us. It was lovely to see the flags in the driveway as you pulled into the VA. Thank you for facilities management that put those up, and EMS that put up the flags. It was nice to stop in the different areas of the medical center on Monday, saying hello to veterans and staff. So again, thank you for all that you did. Hope you enjoyed it and took some personal time for yourself. So a lot of things that are going on in terms of leadership around the country. Many things are being looked at. One of the things is masking. We should have our masking update very shortly, and we'll be able to get that out as soon as possible. Um, we're going to go over a couple of things today to talk about. We're going to talk about the parking lot update. I want us to look a little bit about our SHEP scores, how well we're doing. We're going to talk again about protection of whistleblowers. And we want to focus in on our mental health services, and then we'll leave some time for Q&A. A couple of things that I want to remind folks about. We have an awareness going on for Mental Health Awareness Month, which was May, we're celebrating. Coming in June, we have Pride Month. We also have PTSD Awareness Month and Asian American Asian American Pacific Island Month, which was in June. And for those that didn't have an opportunity, please look at the video that Sean has made. Dr. Sue did a great presentation on calligraphy, and Miss Terry did a great in dietetics, did a great presentation on how to do sushi. So thank you very much for that awareness. Quality and readiness, Joint Commission Triennial Survey for the lab, very successful. The lab was great. I was able to go around, get everyone's reaction, and to thank them for a great job. National Cardiology Office site visit happened in May 2nd. Very good review. It's gotten approval to move to the next level. We'll be focusing in on opening up our cardiac cath lab. We're really excited about that with the leadership. OIG CHIP survey, which was virtual for Was Woman Health. We did very well. And I can't say enough good things about what is coming out in terms of the the women's health arena. So anything else from any one of the other exec team members that are on board this morning? Okay, let's move on. We're going to give updates, and then we'll leave time for Q&A at the end. We're going to go on. Joe, you're going to talk to us about the parking lot.
Yes, ma'am. Thank you. Good afternoon, everyone. This is Joe with FMS. I want to start just by thanking everybody for all their efforts and coordination for the parking. I know it was or it has been something very different than what we've been used to, but it is going well, and we greatly appreciate everyone's support. So thank you. So as you can see, the project is advancing. We're happy with the progress from the contractor. We are on schedule. Phase 1 is scheduled to be complete on Friday, July 7th. So that's a good update. We feel good about the progress. Obviously, I just want to caution it a little bit. You know, this is early in the project, but the contractor is doing a good job as far as maximizing the footprint they have and doing as much work with the equipment that they can fit on site. So I'll say it that way, but we're satisfied with the project so far. A couple things, you probably see those big yellow dome shaped material on site. That's actually a subsurface stormwater storage system. So basically they're digging big holes. They're gonna put those in the ground, backfill it, bury it, and that's what's gonna store the stormwater runoff. So that's what that is. And that's gonna be all completed in phase 1 by July 7th. Before phase 1 is complete, they will have to shut down the sidewalk along the side of the parking lot for 3 weeks. And the reason they have to do that is they need to expand the footprint so that they can access the parking lot from that sidewalk. They're gonna have to basically park the excavator and other equipment on the sidewalk. So for 3 weeks, we're gonna have to close off the sidewalk. We'll coordinate with the PD and all the other services in the hospital that may have visually impaired staff that use that sidewalk on a regular basis. In the past, we've sent out notices and we've provided alternative, I should say, escorts if needed, or we've also provided additional routes to get where folks need to get. So short of anything coming up, I feel good about the project. I think our project engineer, Greg Mapstone, is doing a great job keeping the contractor on target. And that's really that's the update for now. Do you want me to take questions now, Darlene, or wait until the end?
You can take questions now if you want, whatever. I think, Joe, the one thing that I would ask is, when your team is together and you're looking at different things that could occur when it's closed, I don't know if it's possible, but I'm for those employees that may have challenges, maybe we can look at a transport of some sort for their safety. I don't know if we can do that because I know we have rules and regs, but I'm really concerned with the safety when sidewalks are closed for
Yeah.
those. Okay, so
Yep.
think
No, we
about
did.
that.
No, absolutely. So we've done it successfully in the past, but I will definitely make sure that we do provide what other escorts or direction needed. Yes,
Thank
we'll
you.
definitely do that. I mean, are there any other questions that I can answer or comments anybody may have?
I see nothing in the chat box, Joe, so if something comes up, we can always hold it till the end. So
Sounds
why
good.
don't we
Thank you.
move on? Thank you. You and your team are doing a good job. We have Glenn Gilbert, Chief of Patient Experience, talk quickly about our excellence in customer. I didn't mean quickly, but to talk about our excellence in customer experience. And in particular, Glenn, the great work and to celebrate what the clinical staff and administrative staff are doing, patient advocates, et cetera, to improve our customer experience. Thank you.
Right. Thanks, Mary Ann. So in preference to looking at the scores, which are very positive, I just wanted to share a slide. This is the Connect and Care slide from Own the Moment, which many, if not all of you, have seen before. And it's about connecting and caring with the people we're taking care of. Over this past year, we've been asked to take a hard look at some of our patient experience scores to see if we're meeting the veterans mission of getting excellence in care. And we've got some really nice metrics which are descriptive of the fact that people here are committed to the mission of caring for the veterans. We are collaborating across care lines. Many of you have received some survey compliments from veterans who are impressed with the level of care they're receiving. One went out this morning to Dr. Caitlin Holly for her care. The primary care providers, Dr. Upal gets comments, as does Dr. Schwam. And they're just emblematic of the fact that people are really seeking to meet the mission each day. So what we did this past year, next slide, there are a number of toolkits that go out from the patient experience office. And it's not that we're not doing these, and some of you have seen some of these posters around the building. This one's called Take 5, and it's about really connecting with the patient when you meet with that person on whatever their concerns are, accomplishing the healthcare mission, but doing it in a way that tells the veteran, we're interested in you and what's going on with you and listening to you. Next slide. That Take 5 has been particularly useful with outpatient care. And also the inpatient corresponding slide for that is Commit to Sit, which some of you have seen. This is hourly nurse rounding, works for veterans. You've seen that in the rear elevator lobby. Connecting with veterans by nursing staff and medical staff is probably the most important way of impacting a patient's care, getting good communication about what's happening with their inpatient stay, including family here, as you see here. And the next slide. This is on the moment discharge. And again, it's all about communication, talking with veterans, letting them know what's going on, answering their questions of the moment. We've circulated patient advocates on the wards as well to hear veterans' concerns, compliments, recommendations, and suggestions. So it's demonstrating that kind of communication. And so the scores are really reflective of what each and every one of you are doing during your patient care routines and the staff that you work with. So last slide. So these are the current metrics for patient experience. They come out on SHEP every month. Right now, for January, we showed a lot of improvement across the board, really, and some more improvements in a couple of SHEP scores in February. So stress discussed in primary care. We are one of the top VAs in the country, top 10% for recognizing and discussing stress issues with veterans, primarily in primary care setting, although that happens across specialty care as well. PCMHA care coordination is really being aware. It's staff demonstrating that they're aware of what's going on with the veteran, coordinating that care, aware of their medication issues, and really listening to what the veteran has to say. And then the overall rating of the provider went up in January as well by quite a few points. And that's just veterans sending their SHEP surveys in and rating the overall experience they had from scheduling and getting an appointment and talking with the provider and reviewing their current concerns and issues. A lot of factors go into that for primary care. The inpatient rating of the hospital, Albany is a leader in VISN 2 with inpatient care. We made some great strides in January. And yes, we went down a little bit in February. It goes up and down, but a tremendous improvement in January. This will all be rolled up with March's scores for our next sale rating. So rating of the hospital, much improvement. There are 12 factors that go into that. Inpatient care transition, another one that VISN 2 across the board is really working hard on. That's really listening to patients and asking them about any preferences as they get admitted to the hospital. It might be about meals, it might be about communication, it might be about their schedule when things are being scheduled for them. And also when they're leaving the hospital, if they're aware of what their medications are for, what their next step is, who they communicate and what they can expect after that. So we are making some improvements in inpatient care overall. Service connected rating of providers. That is specialty care. That went up quite a bit in February. A lot of work going on with specialty care providers, the rating of the provider, coordination, also making some dramatic gains in specialty care coordination. Hopefully we will see that reflected in our sale reports. And also have added access, since that's such a key issue for veterans and their families as to when they get access. So This is really notes of celebration or recognition of what's happening in our facility every day and the care that we're providing to veterans across the spectrum. That's all I have. If you have any questions, I'm happy to answer those as well.
Thanks, Glenn. A lot of good work has gone into this, so really want to recognize the frontline staff and the inpatient areas and the care coordination in the outpatient areas in terms of the stress discussed. Great strides that have been made in the SHEP score. So thank you very much. What does this mean? I think this just points out to the story that I read this morning. When a veteran walks into this facility, the scores tell us one thing, but how they feel is really what they're telling us. And they're looking around and they went from department to department to department, and everyone had the same demeanor, had the same way in which they approached the veteran. And I think what really struck me is when they were done, especially in pharmacy, they said, "And what else can we do for you today, sir?" And so, great things being done. Thank you, everyone. Thanks. Think about how you personally want to be treated. So thank you. Okay. Next, we're going to go on to whistleblower. I think Mary Ann, are you going to do that?
I am on, Darlene, and I am prepared to do that, yes.
Thank you.
So we talk about whistleblower protection in our town halls and in our supervisor and managers meeting. It's something that we want to make sure is at the forefront of everyone's mind. So whistleblower is somebody who makes a protected disclosure or engages in a protected activity. So protected disclosures it includes a whistleblower makes a complaint about a violation of law, of rule, or a regulation, gross mismanagement within the department, gross waste of funds, an abuse of authority, substantial and specific danger to public health or safety, or censorship related to research, analysis, or technical information. Protected activities include filing a grievance, an appeal, or other complaint. For example, union grievances and EEO complaints. Protected activities also include a whistleblower that testifies or otherwise helps someone else file a grievance, an appeal, or another complaint. A whistleblower that cooperates with or makes a complaint to OSC or OIG. Those are protected activities, as well as refusing to obey an illegal order. So what does a whistleblower have to prove? He or she engaged in an activity that he or she reasonably believed to be a protected disclosure. The employer knew about the protected disclosure and the identity of the employee making the disclosure. The employer, too, failed to take, threatened to take, or influenced an official to take a personnel action against the employee. And the thing that a whistleblower has to prove is the disclosure was a contributing factor related in the personnel action. So those are just a couple of things about whistleblowers. Again, I know it's a repeat, and we continue to bring it to the forefront. There are posters throughout the facility in the entryways and downstairs outside the canteen that also has this information, as well as how to contact the Office of Whistleblower Protection. Does anybody have any questions? Okay. Darlene, I know we're a little bit early. Dr. Payne, I know, was not going to be available until 12:30. Alicia, do you want to read the safety story or I can?
Sure, I can read it. And we also have Ed Maloney on to review our the RCA process. He could go first if he doesn't mind.
So
Okay.
did you need to key this up at all so people understand this, why you're doing this, what you're doing?
Yeah, absolutely.
Thank
So
you.
we do, yeah, no problem. We do our safety forums throughout the facility to help bring to the facility's attention the efforts that we're doing to improve our patient experience and improve the overall experiences for staff and employees. We want to bring safety to the forefront as much as we can. We're all here for our veterans. We want to do as much as we can to help improve the care that we give our veterans. And the RCA process is something that we do for an incident report that was entered into JPSR system or incident reporting system. If it warrants an RCA, we will then get a group of people together and investigate the issue and see what the root causes were and see what we can do to improve the process so that the incidents don't happen again. This has proven to have some really good results within the facility. We've made a lot of positive changes in the facility, and we're really just getting started bringing these things down to the unit level so that the units can see what we're doing behind the scenes to improve our patient experiences. Did anybody have any questions about an RCA? Okay, thank you. Ed, if you're on, if you wanted to go ahead and give us a breakdown of the RCA that we completed.
Sure, I am on, and here we
Thank you.
go. We had a group of staff that did a review of an incident that occurred on February 26th of this past year. 59-year-old veteran was admitted to Dom Sud, and he was in the hallway, noted by staff he was acting irregularly. The veteran was fidgeting with the garbage can, playing music loudly, making bizarre movements. The nurse brought the veteran to the office and completed an assessment, discovered that he was hypotensive and diaphoretic. The veteran admitted to using heroin in the bathroom. A room search was conducted per protocol, and several small baggies containing a small amount of brown powdery substance were found. The veteran was sent to the ER and evaluation and was ultimately discharged. The root cause issues that were noted were a lack of random urine drug screens, which increased the likelihood for adverse events and led to storage of potential use of illegal substances without notice. The action that was taken after that was to set up random urine drug screens. Now, we had done this prior to the start of the pandemic, but got out of that practice. The second issue that was noted was a lack of proper training for protective supplies led staff to staff discomfort with room and belonging searches, and the process increased likelihood of contraband being missed. Staff met with the police and they provided additional training on searches. We found that we needed to use a heavier glove than we were using. Also, not the regular masks, but N95s, and also eyewear every time we're doing a search. Lessons learned: because this is a residential program, veterans can leave the unit without, which will increase the likelihood that veterans are entering the unit with contraband. So when they go to the store, things of that nature, we do ask to search what they're carrying back in. Unfortunately, we cannot do a pat down search or things like that. We can ask them to empty their pockets. And also the search process was reviewed with staff and the Dom Sud police, and new safety precautions have been implemented. Questions?
Hey Ed, it's Annette. I just wondered, do you get a lot of pushback from veterans about looking at their items or doing the searches?
Usually not. When we do a search, like if a person was admitted today, we do the search with 2 staff and the veteran present.
I'm glad to hear that because I would think that all the veterans want it to be safe on the unit, so it probably feels kind of good to them to know that there's no contraband.
Well, there was on this instance, and that's why we've made some adjustments.
So what I would think at this time, you know, for those that are leading this discussion, are you looking to have more interaction or questions from the audience?
Sure.
Alicia? What?
Yes, yes, absolutely. This is what bringing it down to the unit level and the facility level is trying to do. We want your feedback as a facility, and we want you guys to be a part of the problem solving. And that's what we're trying to do here. And if anybody has any questions or concerns and they're not comfortable coming off mute and speaking to it here, you can always private message myself or Melissa Kerwinski, our patient safety manager.
But Darlene, I'm glad you bring that up because I think that was when this first happened. I think that was one of the issues for the staff as they were concerned, we're on 10C, we're nurses, we're social workers, psychologists, medical doctors, we're not police. And so the idea of doing searches and how to do that, it's a little bit scary. And like I said, I was always worried that maybe veterans would be upset about having that happen. And I think Ed and Devin did such a nice job reaching out to the police. And thank goodness our VA police were so generous with their time and to come up and, talk about how to do those kinds of searches, but within the confines of being a clinical team, but then also being so supportive of us around, are gloves good enough for fentanyl? And they helped us to get some better gloves to be able to do those searches.
So
There's
tell
just a
me how
lot.
you kept, and you're right on the money, Dr. Payne, and this is the intent of this safety forum, is that others throughout the organization, or else in the mental health can understand, these things that are doing. So Dr. Payne, do you know how your staff felt with these types of things being done? Do they feel as though it's keeping them safer now?
Well, I think originally when this first happened, the staff were kind of nervous because, what happens if you touch fentanyl and you pass out on the floor? Do people know to give you Narcan? Is Narcan available? I could see some staff saying, oh my gosh, do we give, if I just pass out, maybe people would say, do we just give Narcan or do we send her to the emergency room? How do you know what to do? And, does that mean all the staff need to let their coworkers know, hey, I'm full code, if I drop, please try to bring me back. I still got more life in me. I mean, these are, it's just hard. And I always have heard from nurses about finger sticks with needles. Like that's one of my personal worries is if I was searching somebody, what if I get stuck with a needle? And, I hoped that the staff would feel comfortable going to either Ed or to Devin, or at least to somebody on the team to be able to voice their personal concerns. Because that was really what Ed and Devin were the most worried about is they want their staff to feel safe. Because if the staff feels safe, then the veterans will feel safe.
Yeah.
If the staff don't feel safe on the unit, it's gonna come across to the veterans.
Right. Yeah, I think you've done a really nice job in keeping your staff safe, Ed.
Thank you.
And Devin. I think that bringing this forward, letting them know, having discussion, as Dr. Payne said, having input, making sure we're appropriately trained is really very important. But it's important if we're keeping the veteran in mind, putting them in the forefront, that everyone deserves to have an environment by which they can be treated. And if we have something on the floor, then it's going to impact others. So good example.
Now, this veteran kept the drug in his belongings, but we expanded the searches to randomly searching community area locations as well.
Right. Right. Great. So Alicia, why don't you talk about the pillars and how it's reflected in the pillars of HRO?
Sure, I can do that. the three pillars of HRO definitely came together in this story. Dr. Payne and Penny do have presentations to give, Darlene.
Okay,
Yeah, they have some presentations to do, so I don't want to take up too much time. They've done a
well,
great job putting together some presentations, and we also have a safety story for Dr. Payne. If she would like to,
Well, I
so
was gonna
you're
say,
gonna, Dr. Payne, are you gonna point out the three pillars that went along with this RCA or anything? Is that what you're gonna do?
well, it was kind of a separate thing. We were gonna do a presentation where
Okay.
I'm gonna,
All right, so let me just close out this first part that we did, Dr. Payne. In terms of, you know, it being the pillars would really be there's continuous improvement here and our focus on safety, continuous improvement, and ensuring that we are sensitive to operations. So I just want you for us to focus on that. Dr. Payne, I'll turn it over to you next. Thank you.
I'm so sorry. I don't mean to be bossy and take over.
Nope, you're not. Perfect.
I appreciate being able to tell this safety story. So oftentimes when mental health provides a safety story, we talk about all of the things that happen prior to a person receiving an intervention around suicidality. This safety story is focused on the things that we do after that. So a 59-year-old female veteran had called the Veterans Crisis Line and also the Plattsburgh CBOC to report that she had felt suicidal. This veteran also messaged her cousin about wanting to jump off a bridge because she was having so many stressors. The veteran's cousin actually called the local police, who found the veteran and brought her to the emergency department. At the same time, the VA staff had coordinated with mental health psychiatry, mental health social work, who alerted our suicide prevention team. Suicide prevention, the Plattsburgh CBOC nurse, mental health staff, and community care all work to coordinate the care of this veteran in the community. So community care was in contact with the hospital. Suicide prevention was also in contact with the hospital, and we were trying to coordinate the aftercare for this veteran. And in fact, we were initially looking at potentially a transfer to the Albany VA. Veteran staff worked to ensure that all the clinical team members were aware of the community events and coordinated for discharge with continued mental health and suicide prevention follow-up for this veteran. The action was around flexible and timely response to a crisis, and the result was that the veteran met with the staff and was screened for safety and suicidality. The staff worked together to obtain the needed supports from the community. Suicide prevention, mental health, the CBOC staff, and community care were alerted, and the veteran was taken to the hospital for an evaluation. But then the VA staff worked with community providers to ensure that there was appropriate follow-up with mental health and suicide prevention services. And the alignment to HRO is sensitivity to operations. And the reason I chose this safety story is I really wanted to highlight that it is important to help veterans when they're suicidal to get to the hospital, but it's just as important to coordinate the care after they leave the hospital. And I greatly appreciate our community care team has been really great at alerting the mental health staff around these issues. And then the mental health staff work closely with suicide prevention. As you all know, there's a lot of metrics and reporting that's important with that, but also the case management that goes with suicide prevention to ensure we're providing wraparound clinical services until a veteran can get in with their counselor and psychiatrist. So greatly appreciate all the staff who helped, and a huge shout out to nursing up at the Plattsburgh CBOC, who also helped to really coordinate with mental health. And then this safety story leads us right into, I wanted to just provide a little bit of basic information about our mental health services. Thank you, Alicia, for these wonderful slides. They look so much better than the ones I sent you. So the blue is a very common color. I appreciate it.
that was all Mary Ann.
Well, thank you, Mary Ann. Greatly appreciate it. I love this design. So I'll just start off. One of the things we talk about a lot in mental health is that, we're very fortunate. We have a lot of services that are available. And, we get a lot of new staff on board. We also have, staff who either retire or maybe go to other facilities. And so I just wanted to do a brief update for all the staff about the services that we have in place and then a mental health contact person. So we have our general behavioral outpatient clinic. That clinic has gone by many different names. Right now, we're transitioning to call this a BHIP clinic and to develop some BHIP teams, but it's generally our outpatient clinic. Mary Beth Desario is the program manager for the outpatient clinic. And if you had questions about the clinic, she would be the contact person. Within that clinic, we have so many different services available. Tim LaRose is our new couples counselor. So he is going to be triaging our couples counseling consults. Thank goodness we were able to bring most of those back from community care. The thing that I love about that is that we're able to get people in much sooner than we're able to be seen in the community. We have individual therapy, we have group therapy, we also have some case management, and we have a care coordinator on the team. We provide evidence-based practices for depression, anxiety. We also have some, fairly complex patients that receive different groups like DBT and our ACT group. And so there's a little bit of something for everyone. We have some walk-in groups, we have scheduled groups. Many of our groups are hybrid of in-person as well as virtual. This has been a real blessing for us because it allows veterans who are maybe farther away distance-wise to be able to participate in groups in a virtual forum. So that's a little bit about our outpatient clinic. CDRP is our substance abuse program, and Ed represents that program with Devin Cummings. Devin Cummings is the program manager, so she is probably the contact person. Within CDRP, we have 3 separate programs. One is the outpatient program. The second is an intensive outpatient program. The difference between outpatient and intensive outpatient is the frequency and intensity of the interventions. So in the intensive outpatient program, a veteran might present for 2 to 3 days per week. Outpatient is typically 1 day a week. And in the intensive outpatient program, someone may have several appointments scheduled during the day, individual and group. And then the third program is our DOM-SUD. And that is our residential program. It's a 6-week program. Currently, we have 13 beds available, and that veterans are welcome to come to that program through consultation. And then we do a screening of those veterans and get them on board. This is a powerful program because it can change people's lives. When someone is struggling with substance addiction, it often can impair many areas of their functioning. And so this is a powerful program to get people back on a whole health path, so to speak. PCMHI is our primary care mental health integration program. We have many CBOCs out in the community, all the way up to Plattsburgh and down to Kingston, to the New York border and all the way out to Fonda. Each of these programs have a mental health provider who is embedded within that program, and that's not to be confused with PACT social work. Our PACT social workers are also embedded within many of these CBOCs and help with some of the medical kinds of issues that come up. Our mental health staff that are integrated within primary care provide short-term evidence-based counseling and also some case management. And then, if a veteran needs a higher level of care, they will often refer those veterans back to our outpatient clinic or another specialty care clinic. Tom D'Agostino is the program manager for PCMHI, and he would be the contact person. Our PTSD program also has the ability to do individual and virtual appointments. Maggie Guglielmi is the program manager for that program. PTSD has gone through a massive overhaul within the last year. PTSD had been embedded within the outpatient clinic, and this year they have separated into their own specialty clinic called a PCT, which means that they are primarily providing evidence-based practices, primarily prolonged exposure and cognitive behavioral therapy for veterans who have had combat-related PTSD or MST-related PTSD. These programs have been very effective, and we're looking to expand that program as well. Oftentimes, if a primary care provider is putting a PTSD consult in, those consults will be referred back to the PCMHI mental health provider to do a screening just to determine the eligibility requirements for the specialty PTSD clinic. Our next program is PRRC MICM. So within the PRRC MICM program, we have 3 separate programs. One is the PRRC program. This is a kind of a pseudo day treatment program, and it involves more active participation with groups as well as some individual treatment. But there's more case management that occurs. So these veterans are typically may have more serious mental illness or a psychotic disorder. And so their provider is probably talking with them at least once a week and sometimes twice a week. And veterans may even attend group on a daily basis. MICM is also an intensive case manager. We have some of our 10A nurses as well as MICM case managers that go out into the community and meet with veterans where they live. It's a community-based program, and the goal is to help these veterans stay in the community rather than having to have maybe an inpatient psychiatric hospitalization. We provide, additional support and services out in the community. And then we also have an E-Range MICM program, and there's a small team of social workers that are up in the North Country, and they will meet with our veterans up in that area, either in their homes or sometimes they'll meet with veterans up at the Plattsburgh CBOC or Westport CBOC. And again, Jen Courtney is the program manager for that team, and she would be the primary contact. We also have a very impressive homeless program. So Maureen Corbett is the program manager for our homeless team. There are a number of different programs within the homeless team where they're able to provide emergency assistance, but also long-term assistance. They'll meet with veterans and find out what their financial, social, emotional, mental health, substance abuse needs are. We have a pretty fantastic walk-in homeless program. So a veteran can just walk into the building and meet with a homeless team member who is on call that day. And many times we're able to find emergency housing for them that day. Tina Mead is also, one of the program managers within the homeless team. Our CWT program is compensated work therapy. It's like a vocational rehab program. Maureen and her team just had, and I see Penny, you're on, you might be able to speak to this since you went to their summit. I think it was the first week in May where they had a job fair over at the Vision. And, their biggest goal is to help veterans get a job. And I'll just say that's one of the founding principles to help someone get their life on track is to have a job. A job gives a person meaning and purpose, and to be able to help a veteran find a job where they fit in well and their skills are well accepted and maximized is a true gift. And one of the things I'll just say a little bit is, prior to COVID, Maureen had a yearly celebration around the holidays. And I can tell you, going to that celebration, there would be so many different veterans, and they would often say, you know, CWT saved their life. And so just a fantastic program. And then suicide prevention, Michelle Woodcock is the suicide prevention coordinator. And again, this can involve case management. It can relate to, you know, acute events and crisis intervention. And Michelle has, you know, 4 separate staff that are now working in suicide prevention. So fantastic team. I know I'm getting close on time here. Next slide. And I just wanted to give a shout out in the emergency department. Kiana, you can see Penny Deasy used to be our mental health social worker in the emergency department, and she has transitioned to a new position as our local recovery coordinator. She'll be telling us a little bit more about that. But Kiana Polasek had transitioned from our suicide prevention team to the mental health worker in our emergency room. And I didn't put Joy's name here, but Joy Aaron is also one of the ED social workers who works on the medical side. But I can say truly our mental health social worker and our medical social worker in the ED help each other. I don't know how many times I've seen them, you know, coordinating and collaborating to try to get the services that are available. So I'm just grateful, such a good team in the emergency room, as well as our ED friends in physicians and nursing. So shout out to them. And then on the inpatient unit, one of the programs that we've developed is having some intermittent social workers who work on the weekends. That will be one of Penny's new, you know, tasks that she's really going to focus on, is trying to build some of the recovery oriented mental health programming on 10B that's available to our veterans on Saturdays and Sundays. We're typically more busy and have more active programming during the week, but on the weekends it can be awfully challenging, and it's nice for them to also be, you know, getting some of those services. And last slide. And I'll just transition Penny Deasy. She's going to be giving us an overview of our mental health summit that was on May 16th. And I'll just say, you know, Penny's been a fantastic addition to the whole mental health program. She's taking over several SAIL metrics, as well as some supervision on the inpatient unit, and then also taking over as the LRC, which is quite a big function. So Penny, I'll turn it over to you.
Thanks, Dr. Payne. Hi, everybody. My name is Penny Deasy. I know many of you, and you've probably seen me throughout the hospital. And, you know, I just want to talk a little bit. A lot of people ask me, what does the local recovery coordinator, what do you do? It's such a difficult thing to define, but there was a directive that came out years ago, and it's been changed a little bit throughout time, but it's basically a leadership kind of position that cuts across every department in the hospital. It's transformational change. So it's kind of like a shift in thinking. So it includes the veteran. It's more inclusive of the veteran's goals, the veteran's voice. So it's transforming recovery-oriented inpatient and outpatient care environments. Next slide, the guiding documents. Like I said, there was a directive that came out from CO, and that's how I base most of what I do. It does include having an annual mental health summit, which we just did a couple of weeks ago over at the Vision Building. I worked with the suicide prevention community outreach providers, Jennifer Corradolo and Michelle Chavarria, and we were able to do an in-person event, which was great. We had about 100 people in attendance, and we got such really good feedback. We had NAMI come and talk, the Center for Problem Gambling. We had a veteran peer support panel. It was just really wonderful to be able to do that again in person. And I look forward to doing it again next year. Another one of the pieces in that guiding document has to do with outreach. It's called the SMI Reengage program. So I am tasked with reaching out to veterans who have a severe mental illness and have not engaged in any kind of treatment or care at the hospital, regardless if it's physical or mental health, and trying to get them to come back in. And that's been very successful as well. Another piece is having a Veterans Mental Health Council. So let's go to the next slide. Collaboration. So strengthening and amplifying peer specialist roles and perspectives. So having that Veteran Mental Health Council really gives them a voice. It helps them to feel seen and heard, which is good for everybody. It helps to prevent a safe and welcoming environment for the veterans and for the staff. If they feel confident that they're not going to be exposed to any discrimination, criticism, harassment, or harm, then they're going to feel better about their treatment and they're going to keep coming back. So the Mental Health Council provides inclusion, empowerment, and advocacy, which are 3 staples in the recovery movement. And it's good. It helps with de-escalation techniques down in the emergency room or anywhere in the hospital. It really works well with suicide prevention because people have a voice and very often they just don't feel like anybody's listening to them. So we empower people to make connections and foster hope. Part of my role is doing the mental health environment of care. So you'll see me on 10B or 10C walking around with the environment of care people, looking at what's recovery oriented, what's not. You'll see that there are artworks done by the veterans up there. It's really nice. It promotes inclusive documentation, using recovery-oriented language to reduce stigma. So think about the language that we use on an everyday basis and how it might impact somebody else if they overheard you saying something that wasn't recovery-oriented. I'm a role model. I have to use person-centered language. And if I find myself not being there, or if I hear somebody else, then privately, maybe pull somebody aside and say, hey, have you ever thought about it this way? Like you said earlier, Darlene, how would you want to be treated? And that's so true, right? I align very closely with Whole Health and all of those programs here at the VA. Talking recovery and treatment teams and in the milieu. So we focus, it's very strengths-based. Next slide. So converting staff culture, that's part of it, right? So it starts from the top down with the directive, developing a work group and champions with that work group. So part of what I'm going to do is go around and talk to people who are interested in maybe joining a work group with recovery, and they could become champions in their area and help to promote this. Identifying stigma on our own and taking a stand. So if you hear some kind of a statement, maybe challenge it sometimes. Highlighting and acknowledging veterans' strengths and progress. So I meet with a lot of staff here and just kind of remind them that this is about their strengths. And so often veterans have been told about their weaknesses, their weak areas, their problems, maybe trying to look at it from another angle and look at it as a strength instead of a weakness. Regular educational trainings for staff, obtaining feedback from veterans via a unit survey. So we're in the process of developing a survey for feedback when patients are discharged from 10 Bravo. So that's going to be helpful as well. Why do we do this? To create that safe environment again, and with the belief that recovery is possible, right? So you have to have that kind of belief in order to be able to live these values. Next slide. So here's some of the ideas. I was at what we call the Local Recovery Coordinator Boot Camp a couple of weeks ago. And this slide I actually borrowed from them. It talked about different ideas that people are doing around the country. So they have a recovery resource library, fitness rooms. I know that they do have a fitness room over on 10C in the Dom Sud. AA meetings that come in, chaplain-led groups, peer support, music, gardening, including families is really important. Offering choices in care. So all of these things are really important. The main thing is that it's self-directed and that we help the vets to, focus on their strengths, their resiliency, what's worked for them in the past, and goal setting. What do they want to do for the future, whether it's short term or long term? I look at it as providing hope, always providing hope. I loved when I worked in the CWT program and we could always give people some hope. Empowerment and intake, one of the strongest things that I left the boot camp with a couple of weeks ago was a statement that many of these folks have lived their whole lives with people saying to them, "What's the matter with you?" Right? So how many people have ever heard that? Instead of thinking of it in those terms, think what matters to you. And that should be the guiding thing for their treatment plans. So most importantly, think about your biases, your assumptions. Self-knowledge is really, really important, and challenge yourself. Be authentic with the veterans. Challenge yourself when you feel like those biases or self-assumptions are coming in. Remember that we have power differentials here. As providers, there's an inherent power imbalance, and that always puts the veteran, on the other side. So, awareness of that. Collaborate with them, collaborate with the veteran, other providers, peer supports and families, offer choices and feedback. Next.
Penny, I'm sorry to interrupt. Oh,
Yep.
perfect timing. Questions.
Yeah.
One of the things I really appreciated that you did at the mental health summit was to talk about stigma
Yeah.
and, the faces of recovery and really focusing on trying to break up stigma about mental health. I think sometimes people are reluctant, and veterans especially are reluctant to present and ask for help because they, have some concerns about, what that might mean. And
Yes.
I think over time, society has done a pretty good job of being more inclusive and aware. But I think there's still some stigma about having mental health issues. And I think you did a really nice job of addressing that at the summit.
Yeah, it ended up being a theme. I mean, when NAMI first did the opening talk, they talked about stigma, and we called it the many faces of recovery. And it ended up that every presentation after that talked about stigma as well. So stigma it's one of those barriers that keeps people from asking for help. And if we can try to address that and reduce stigma, then maybe, we can help somebody to get back on that road of recovery again. So there was so much more. I mean, I have so much, I could go on and on and on and on, but for any questions, if anybody wants to learn more about some of the stuff that I can provide, if you want me to come and talk to your teams, let me know. It's penny.dc@va.gov, and my extension is 67391. Thanks.
Yeah, Penny and Dr. Payne, first of all, Dr. Payne, thank you for your leadership in this arena, and Penny for yours as well. I think the things that really hit me well is the focus on the cultural piece, how important that is, because you're going to influence any of these strategies, and unless you address those cultural pieces, you're not going to be able to implement successfully the strategies. It's no different than anything else that we do. The stigma piece really stuck to me as well when we had that piece, and I wholeheartedly agree with Dr. Payne. The stigma with everyone, whether it's a veteran, whether it's an employee, or whether it's anything that we do, we're so we may have the fear that someone's going to hold it against us, so we can't go to that next level. We can make that change, and it's the little things that we do. Penny, great job. Thank you.
Thank you.
And
Okay.
Darlene, we're at the end of our town hall.
Yeah, so are there any questions or comments? I know we wanted to celebrate all the things that we're doing, not all, but some of the things that we're doing in mental health. We wanted you to be aware. Uh, Anything else that we may have forgotten?
Oh, yes, I did want to say that on Thursday, June 1st, over at the Vision Building, the Caregiver Support Program and Mental Health, we're having a combined, just a mental health fair, a walkthrough. If people want to come, it's from 10 to 2.
Okay, that was a beautiful way to end Mental Health Awareness Month. So thank you. Anything else from anyone? You have any other questions about the rest of comings and goings and things that are going on in the organization? Okay. Mary Ann, I want to thank you and Sean for keeping this going for the town hall. If any of you have other topics for town hall you'd like to hear about, please let us know. Send an email to Sean or Mary Ann, and we will ensure that we keep it up. Okay. Everyone have a good afternoon. Thank you.